Thank you. Chairman, ladies and gentlemen, thank you very much for giving me this opportunity to share some of our experience at the Wolverhampton Heart and Lung Centre. You've heard, first of all, I've got no disclosures. And you've heard earlier from Mo, who worked together with me, how our MDT works. One of the important part of the MDT is all this piece of paper you see on the table, where we actually have a pro forma, which we used to document patients' comorbidities, previous investigation results, and then at the bottom of the pro forma, there is the decision of the MDT. I've not put a slide of the pro forma because, as Mo already showed, we are moving to an electronic database. For the purpose of this talk, I've had to go back to some of those paper records, and I looked at some of those which we used in the year 2012 to put this talk together. It's all very nice sitting together in a very amicable fashion to work out what's the best for the patient. But then what happens afterwards may be something like this. People start fighting to decide what they're going to do. But luckily, that's not the case in Wolverhampton. The time that I had on my hand, I managed to get through just under 950 of these paper sheets. And basically, I looked at, for these 950-odd patients, what was the outcome of the MDT. And it was fairly well split between a recommendation for coronary surgery and PCI. And then a smaller proportion of patients either were deemed for medical therapy or from further investigation, either a pressure wire or a dobutamine stress echo, to try to work out what would be the best option for these patients. And the purposes of my talk is to actually go through each of these decisions and see what happened afterwards. And I have to thank Mike Norell, who is one of our cardiologists who's kindly joined us for this session, to be able to be very transparent in the decision-making. What happened afterwards is also very important because there's no point spending time making a decision and then not doing anything about it. When I looked back at all these 950 sheets, I found that actually we were pretty good. 96% of the time that we said this decision, this is what actually happened. And I think we were asking earlier on, why do we need an MDT? And I think if you set yourself out spending time discussing your patient, this may be fairly close to what will end up in your unit, is that whatever decision you make, it will be carried out. However, there were 4% of patients, that amounted to 40 patients out of those 943 patients, where something different actually happened. And I thought it would be nice to share that little bit of data with you just to see whether we can improve in the future in the way we make our decision. So where did these changes occur? Out of these 40 patients, 16 who were recommended for CABG did not get a CABG. Only one who was recommended for PCI didn't get a PCI, and we'll see why in a minute, and so on and so forth. So let's look at the CABG group first. Why did the 16 patients who were recommended for CABG did not get a CABG? 7 of them, when they were approached by the surgeon, they were referred to a surgical outpatient. They discussed the risk-benefit of a CABG. The patient decided, having had a balanced view of what is best for him or her, that they didn't want to proceed to a CABG. And that will happen, I think, in any practice. There was about 8 patients where there were further comorbidities identified at the time of the surgical review, which was not apparent at the time of the MDT discussion. And given that those comorbidities were present, surgery was deemed probably slightly more risky than a PCI, and the patient was represented at the MDT, and a PCI was carried out. And there were 2 patients who were seen by the surgeon, was on his waiting list for CABG, but unfortunately came in while waiting and underwent a primary PCI to the LAD, so hence the need for surgery was no longer necessary. There was one patient who was referred for PCI, and he decided he didn't want to have a PCI because he believed in the Almighty and he thought he will get better. Unfortunately, later on we found out that was not the case, but he didn't have his PCI. There were a couple of patients who were recommended for medical therapy, that treatment modality was changed, either because of worsening symptoms, or one of them actually came in the middle of the night with an NSTEMI and underwent a primary PCI. And finally, for those who were recommended to have some further investigations, there were a couple who came in while waiting for these investigations with an NSTEMI and underwent a primary PCI. There were a few who had comorbidities which we were not aware of, people referred for DSE, for example, with arrhythmia, and were not suitable to have a DSE, or instead of a DSE, they had a cardiac MRI performed instead. So there is a bit of aberration. In our practice, it seems to be a very small number. Majority of the decision of the heart team, when it's performed properly, we think, then would be carried out. And there are still some factors which is unknown at the time of the heart team discussion, which I don't know whether we can incorporate that within the heart team discussion, and these will include things like the Euro score, maybe the syntax score, and also the patient, because as you saw, there were a number of aberrations which were patient decisions, and we may have a discussion later on how we include patient within our heart team discussion. Thank you for your attention.